I wanted to talk about today is really, the idea of what is, kind of self-funding, where it is in the marketplace, you as a broker consultant, what you can do with it, and then the last part is to really go into our product that we've been extremely successful with throughout the country. So with that, I'll get things kicked off. Kind of the objectives, what we want to do is kind of look at the healthcare environment, and again, I know everybody is dealing with a lot of these things. Talk about the funding strategies, where we see it going here in the near future, especially, who knows with the election, even post-election. Self-funding is never, is not going away. If anything, it's picking up at a rapid pace. So we want to be make sure everybody's prepared for that, and then get into our key healthy partner position. From a current healthcare environment, again, employer, nothing that probably anybody doesn't know is that employers are spending more on health insurance while employees are more dissatisfied with their health benefits. The primary issues, that we're all dealing with, healthcare reform, the government regulations, MLR requirements, escalating medical costs, consumer entitlement, managed care backlash, the burden of the healthcare administration, the regulations, the increasing number of the uninsured. And I will tell you, just in the marketplace throughout the country here, and just in the last couple of weeks, the ideas of the fully insured carriers, where the MLRs in the last, I would say last year at this time, where you started seeing flat renewals and decreases, everything we're seeing being told from competitive sources is, it's 15 to 20% and going up. So again, we want to show you definitely an alternative to fight those pressures. Kind of, also what a broker's employers want related to healthcare benefits. They want them to be affordable. Want to make sure, that we're not forced out with, that they just shut it down and go to the exchange, etc. They want it to be manageable. They want it to be attractive and competitive. They want to, try to keep their employees healthy. And they'd like to have transparency of knowing where every dollar is being spent. That's definitely what we can do for them. What do they get now? From a fully insured side, they receive annual quotes, determine how to shift cost, move the deductible here or there. 80% of the time it's, spent on fixed cost. No investment in managing the chronic conditions or wellness, meaning what I mean by that is if we can make it healthier, then we should see better results, whether it's fully insured or self-funded. And make decisions based upon little or no actionable data. We don't get, other than getting a renewal, and sometimes, here's the premium versus the claims. I can't tell you anything else. I can't tell you, who's having a physical. I can't tell you any of the things that you want to truly manage your plan. That's what I think that we're going to show you something different today. Again, some of the strategies: raising deductibles, lowering co-insurances, increasing employee contribution, eliminating certain benefits. We went to high deductibles the last couple of years. We've introduced HSAs. People buying on just based on perceived high discounts, where discounts are, important, but I will tell you the carrier that boosts themselves that they've got the best discounts in the United States, their average increase right now is 18%. If you've got the best discounts, it's tough to be able to say you're managing cost at 18%. Some of the things from, some employers pay more for healthcare benefits than others. Looking at lower cost practices, again, implementing clinically based care management programs, doing health risk assessments, doing physicals, doing blood work, using cash-based incentives to drive behavior. You're also starting to see compliance versus non-compliance rates, which you can go up to 20% differential this year and 30% next year, and when you're trying to strategize with your employer and putting some skin in the game. Practicing excellence in administration and communication, again, from the broker, employer, HR side, everything, everybody being involved with it. Then the high cost practices, not implementing any kind of wellness, promotion, education, not looking just beyond high discounts from the carrier when choosing their network, using deductible copay levels to drive behavior, and having undesirable levels of employer turnover. So all these things we want to address today. Why should the employers be engaged in things such as that? Again, satisfaction truly gets back to attracting and retaining employees. Again, when employees are being asked to be more active and know a strategy that's being set by their employer, they like that. They want to take part in that. Employers' HR departments are the #1 source consulted for advice during open enrollment. Again, and being able to enable our employers and our HR department with the ideas that the brokers and consultants have brought to the table. And again, from increased productivity, positively impact absenteeism, workers' comp. Again, all those things do drive together. So what we want to do is be able to attack that. From a funding side, really there's 3 different ways to fund healthcare. You've got the fully insured, which again you pay a premium, $10,000. I'll use the example, and you walk away after the year. If it didn't work out, it didn't work out. There's alternate funding, which we're going to talk about today, which is kind of a hybrid, a baby step away from fully insured, still an ASO, which means administrative services only, a self-funded concept, and then traditional self-funding, where they're truly self-funded. So all the way from the low level to the high level is what we want to talk about here. Kind of the funding strategies. More employers today are exploring self-funding and alternate funding strategies to reduce cost. They're looking at different ways to get away from the Obamacare. From the brokers' side of things, the ways to still be paid and be part of the game versus being cut out, whether the carriers are going direct or whether I'm being cut to a PEPM. Majority of individuals with private health insurance are enrolling in self-insured plans. A stat from back in the past, 2008, the private sector workers who were employed at small firms with health coverage, again, 12% were enrolled in self-funded plans. In contrast, the private, about 65%. And then one of the things that came out, dispelling some of the myths in 2011 is that, the increase in small employers doing self-funded is just at a rampant pace right now. Again, assuming that you can protect them, assuming you can talk about what are the protections and eliminate the horror stories, that's what the employer wants to hear about, as well as you as the broker or consultant. From a funding continuum side is that, we look at all the way down, I would say the most conservative, where we go down to a fully insured side, all the way to the most aggressive, a true self-funded plan. And today we're not going to be focusing on anything truly self-funded, which is that 10,000 life employer. It's going to be more the small group as well as the baby step away from fully insured, and then the traditional partial self-funding. Some of the things when we talk about healthcare funding with healthcare reform, on the left side, just kind of compare and contrast. In the fully insured side, you've got a fixed cost. You pay a fixed amount regardless of utilization. In an alternate funding or self-funded, you do have a maximum liability. You participate in the claim savings by placing a cap on the employer's financial liability. The big point here is cap. The ability to put the monthly caps, the annual caps, everything that has been a horror story about self-funding. Again, let's put that myth out of there. In a fully insured, the set premiums they're set for a plan year. In the alternate funding, the product we're going to talk about today, which is Key Healthy Partners, the premiums are set, and we'll talk about the differences there. In a self-funded side or partial self-funded side, they can be set, but they're variable in the fact that if the client doesn't spend the money, they don't have the claims, that money stays with them. In the fully insured side, their standard plans, plan A, 1 through 10, A through F, all kinds of different things. There's a little bit of flexibility. In the alternate funding or partial self-funding, again, increased flexibility. There's not really set plan designs. You design around deductibles. You design around co-insurances. You say you want this or that, so you have a lot more flexibility. Limited plan data in the fully insured side, and then in the alternate funding and the self-funded side, it's client-specific claims data provided. It's full disclosure of everything, full transparency. So again, if you went and spent $10,300 in claims last month, to the penny, you would see what is being spent. And it leads me to throw the question out that in any of your business today, would you ever write a check for $10,000 without getting a receipt? The answer is no. And again, it's just the way it's been in the fully insured side. Well, you as a broker consultant, let me show you something that I can show you transparency. I can protect you. I can give you all the advantages that you have fully insured, but allow you to get away or not have to abide by some of the Obamacare healthcare reform things that are out there, but protect you, protect you, protect you. The fully insured side, again, state and ERISA apply. ERISA, again, from a regulation, so the state and Fed. In the alternate funding or self-funding, you do not have to abide by state mandates. Only the federal guidelines appear. What I mean by that, that doesn't mean no state mandates are covered. In each state, we look at different things, and the ones that are applicable would be. But I will tell you an example. In Ohio, for example, the state guideline is that the dependents can be covered to age 28, where the federal guideline is 26. The federal plans would stick, the self-funded plans would stick to the federal guidelines, which is 26. So again, a little bit more control for your employer. On the fully insured side, typically it's a formula renewal. On the alternate funding and self-funded side, you know exactly how you're running. You know what you should expect. You have the ability to negotiate a little bit more with having data versus not having the data at all. The fully insured side, you see it, the data once a year, typically. And the alternate funding or partial self-funding, the data is there to support a long-term healthcare risk management side. And again, those are the terms you're going to hear a lot: healthcare risk management. You're managing the claims for your employer to help manage renewals, to help stabilize rates for multiple years, and to be able to design plans with data versus just shifting a deductible here or there. Fully insured side, the MLR applies, the rebates, employee-employer. In the alternate funding side, the MLR does not apply. In the alternate funding, the rebate goes back to the employer if there's a chance of a refund. And the partial self-funding, the employer is not spending the dollars on the claim, so that money stays with them. One of the things we put together, just looking at, on a big picture over the next 3 years, the impact of fully insured versus self-funded that we see. Again, this is, an opinion that's come out from many of the different self-insured world, is that what is applicable in the fully insured, what's not applicable in the self-funded, the minimum loss ratios, the restrictive minimum essential coverage, the increased federal taxes. Again, there's a $2.4 billion sector tax that has to be paid for by the fully insured side by 2014. You're going to start seeing that pass through from a rate increase side. The fractured risk pools, again, people jumping to the exchange, people doing different things is going to mess up the different pools. And then the rate adjustment control. Again, coming up, the idea of the age rating being taken out and the 3-to-1 ratio of what has to be in compliance. So again, all those are not applicable in the self-funded arena. And what we see from a really on a PEPM basis, we were just trying to put a number to it, but we see almost a 38% difference in cost. Again, if you can manage the risk, et cetera, in the self-funded side of things you can control, where in the fully insured side there's things that are out of your control that's done basically by the government and what's come here with healthcare reform. Now again, who knows what's going to happen with the election. Our opinion is that there are going to be some things that stick, some things that might not get funded, et cetera. So this is where we're at, just looking at over the next 3 years. Now kind of jumping into that, giving you as to where we see alternate funding, partial self-funding, et cetera. Now jumping into kind of alternate funding for small to mid-sized employers. The product we're going to talk about today is Key Healthy Partners, and it's a product that's geared for employer groups 10 to 125 covered employees. With this product, you're going to see the advantages that we've talked about in the previous section. This is just a baby step away from fully insured. It truly allows that employer to take advantage of it for the healthier groups to take advantage of lower rates than what they're at with the fully insured side. But the biggest thing is to be able to have risk management, to be able to have reporting, to be able to look at the data and also be protected. Just from an opening side of things too, is from our side of things, Key Benefit Administrators is who I work for and in charge of sales for our organization. To give you an idea of the background of the product and who we are, just a quick and dirty here is that we've been around since 1979. With Meritain being purchased by Aetna, it moved us up to the first or second largest independent TPA in the United States. We focus on fundamentals a bunch. You have to do the fundamentals, paying the claims. We're headquartered out of Indianapolis, Indiana, with about 300 or so employees there, and we also have our national service unit in Fort Mill, South Carolina, which has a couple hundred employees there. The difference with us is that from a TPA side of things, everything is our own. It's our nurses, our fulfillment, our customer service. We don't outsource anything. We're not outsourcing it overseas. We're not outsourcing anywhere else. It's with us. So the idea of being able to have everything collaborative, the idea of being able to have systems talk, it's able to deliver results that mean something versus you piecemeal a piecemeal approach. The biggest thing that I would tell you, the difference maker from whether it was a 30,000 life case or a 10 life case, is really the the risk management tools. The idea that we manage 27 chronic conditions There was a stat out there a few months ago that 80% of claims for most employers are driven from 33 chronic conditions. We manage 27 of them. Our competition in the fully insured side, some of the fully insureds manage 6, some manage 11. We manage 27. People say, well, is that too many? We would tell you that we've done the studies over the past few years. We used to be at 18. We added 9 more 2 years ago. Pre-diabetes, pre-asthma, and one of the biggest things is mental health. Mental health leads to a lot of different things that are being measured. And when people talk about being able to measure and talk about these, we're going to show you some things later on that it truly is able to give you the proof, down to the point where, the nurse called this member on this day. This member is a risk stratum 3, and their next 12 months costs are going to be $22,000. It's not giving you just a one-page summary like you get a lot of times in a chronic disease management program. It's actually giving you the detail, being able to work with your employer to actually strategize and plan designs. High tech, high touch. Again, one of the things, the nurses, we've got 28 nurses on our staff. The difference here is that anything about any kind of wellness or chronic disease management program, it's all about engagement to the employee. One of the things that we use different is that in a typical DM, disease management program, and somebody, let's say for an example, is a diabetic, they reach out to that member and say, you're a diabetic, you need to do this, this, this. The first time you tell somebody they need to do something, they turn you off typically. With our nurses, they are trained and make use of motivational interviewing techniques, and in that side of things is they're calling the member up, tell me what your doctor's doing, tell me about this, tell me about that. They're also going to the extent of, truly looking at prescription compliance. When a member who is a high risk is not taking their meds and we see a script not being filled, we reach out to that member. Again, it's all about engagement. The first time somebody says, stop calling me, I want nothing to do with this, we stop. I will tell you in our entire book of business, less than 1.6% opt out. It has been effective. It has been, something that is different. You'll see a slide about ROI on that later on. And then finally, it's a strategic role with each client. With INA's team and our team is truly trying to put out, executive summaries, giving analysis, helping with, design a wellness plan for me. Show me what's going on with my plan. What would I do with this prescription data? How is this working? How is that working? It's truly managing, one of the stats or comments we'll make here is that manage the business like it's an asset, not just, you're paying a premium. And that's what we're trying to do here. Some of the advantages with this product, we're looking at lower rates with preferred risk. We are cherry picking our cases. When I say cherry pick, is we're looking for a typical case. We're looking for, again, depends on size. When we talk about a 10-life case and it has 2 cancers, that's not a risk that's going to go through with us. But a tier 1, a tier 2, a tier 3 type risk that you're getting from the fully insured side, from the self-funded side, that you know what the risk is out there, or that group that just had a 40% rate increase and their 2 largest claims just came off. We underwrite from a prospective risk. We're looking at what is going to happen in the next 12 months. Yes, it's there in the past, but if all of that's just come off, that's a different type of risk. We're not here to shadow price. When you work with the folks at INA, they have the ability to move the rate basis, and they can discuss that with you later on. But the ability that it's full transparency, as low as we can go, as high as we can go, and what the rates are. So we are not shadow pricing rates at all. The idea of knowledge is, knowledge is power. Full disclosure where every dollar is being spent allows you to gain control of your healthcare cost and be able to truly look at what are we doing with it. I get it. A 10-life employer is just trying to keep the lights on. That might not be applicable to them. But as you go up in the marketplace, you're going to see it is definitely important to those employers, as well as it differentiates you as a broker. Begin to manage your assets versus simply paying a premium, something I talked about just a minute ago. The comprehensive risk management for groups between 10 and 125 lives. The same thing we do on a 30,000 life national count, I would take down to a 10-life case. The same exact risk management, the same exact how we operate. They're not going to get 40, 50 reports like a 30,000 life case once. They're going to get their handful of reports, etc. But again, the whole idea of what we do at the large case, we definitely do at the small case as well. The detailed reporting that answers the so what question for an employer. Again, it's one of the in the conference back here, conference that INA had, is one of the things I focused on was kind of the so what. And it's something I challenge everyone with, is that when you get a report back, whether it's from us, it should not, from us, we should be able to answer every question. Meaning, don't just give me a report that says my claims are going up. So what? Tell me something I don't know. How about your claims are going up, your risk factors are over here, here's what you can do with it, and here's a plan of action, and here's what the results should be. That's what we want to do. With this product as well, one of the things, I talked about the example of the receipt, but it's also, when we talk about risk management, if you ask that small employer on the workers' comp side, the mod factor, it's a big thing too, is, tell me about your mod factor. And that small employer can tell you a lot about the mod factor and what they're doing about it. And mod factors, for those that don't know, mod factor is your risk score on your workers' comp, based upon how you're judged and rated. Well, one of the things that we can do for you as well with this product is be able to give you that, a healthcare risk index, a healthcare mod factor. So when you're asking that employer is, what's your mod factor, tell me about it, and then you ask them what's your healthcare risk index, what's your healthcare mod factor, it's typically a blank stare. Let me show you something different. Let me talk to you and bring you something different to the table that you haven't seen before. It's going to protect you and going to focus on risk management and truly hopefully stabilize your rates over multiple years. That's kind of the spiel that we're going in with and having a lot of success with our brokers, consultants, and partners of INA. Potential refund based on a good claim year. Again, with this product I'm going to show you is that it's 75% weighted fixed cost and 25% variable. This product is not about getting a refund. This product is about, being able to manage the risk, being able to have data, being able to have a baby step away from fully insured that allows the employer to get some insight as to what's going on with the plan. Again, we've had 16 or 17 groups have gotten a refund. It's not about the refund because the client has to run at less than 25% loss ratio in order to get it. It's all about the last point. Risk management brings more rate stability. Two things that stick out with us is that our persistency over the last 4 years has been right around 95, 96%. And then again, in the small group arena, that we stick our chest out a little bit and say we think we're different. The other thing is the average rate increases have been less than 8.5%. Again, two things when a small employer that you can say, here's the product performance, and some of the things that Mike and his team have is some of the marketing materials that you'll see from the sales toolkit that truly will differentiate you and bring you bring something different to the table. If it's a prospect or an existing client, that hopefully will get you in the door. The idea here is what I try to talk about here is I want to demyth all the horror stories. So when you typically think of self-funding, and again, there's a lot of different plans out there today and more coming. There are the aggregate-only plans. There's the level funded from a couple carriers. There's some different things that are out there, and I want to talk about, let's demyth a lot of those horror stories. Sometimes you get a bad rap from self-funding. First of all, it's one monthly bill inclusive of all components, similar to fully insured. There's not a min-max expected. There's not a bank account to set up. There's not a lot of the moving twists that typically happen in a self-funded arena with this product here. So if it's $120,000 a year is the premium, you're going to see 4-tier rates just like fully insured rates that are, here's max funded rates. It's $10,000 a month the employer's going to have, whether they have $1 in claims or $1 million in claims. The concept is max cost, truly max cost. So it's, again, when somebody says, well, I'd like to have the ability to get more refunds. I'd like to have, okay, we would step you into a partial self-funded. This is just a baby step away from that fully insured, and then if they run well, they have the data to say, you know what, I want to take the next step now. So that's what we're trying to do is truly give baby steps before we walk here. The automatic advance funding arrangement. This is one of the big myths out there as well that typically employers have gotten burnt in the past in that the example is I have a $10,000 monthly cap, but all of a sudden I had a $30,000 claim. Well, all you got to do is you got to front that, and then we'll reimburse you 30 days later. Small employer, that'll cripple them. They can't have that happen. So automatic advance funding arrangement means spec advance, ag advance, it's automatically included so that they truly have $10,000 a month. There is no, they have to front money, anything like that. Let's talk about another part too is who is the paper on the product? The paper is the most concerned. KBA, Key Benefit Administrators, we are the TPA. RGI, which is an MGU, which is a Managing General Underwriter. We are the underwriter of the product. We have the power of the pen for companion. Companion is the paper on the product. Companion is the second largest Blue Cross Blue Shield affiliate based out of Columbia, South Carolina. And at the end of the day, if something were ever to happen, who, because the question comes out, if everything went all to heck in a handbasket, who is, ultimate responsible if, dire straits come? It's Companion, which is one of the things you want to look at is what is their rating. They're an A-rated carrier. It's the second largest Blue Cross Blue Shield affiliate, so you do have the backing of somebody strong. But we have the power of the pen for Companion. So it's our underwriters, it's our administrator, from an administration side, it's us on the program management. So I wanted to bring that up in this part too, because what comes about is we talked about max cost. So they have an annual cap. I'm going to use that example of $120,000. They're going to have a monthly cap. I'll use the example again of $10,000. But they're also going to have a pulling point or a specific stop loss. In this arena with this product, we look at pulling point, and it's automatically assigned based upon case size. So the example is a 10-life case is going to have a $10,000 pulling point, and about every 8 to 9 lives it goes up, it's going to increase by $5,000. How does that help you or your employer? The example I would give you is a 15-life case. Everybody's running well, but they have this one heart attack. It was $120,000. Guy had a couple stents put in. He's good to go going forward next year, but what happens at renewal time? Well, with us, only $10,000 of that claim would go out against our experience, versus on the carrier world, many times that full $120,000 is going against your experience. So again, a monthly cap, a yearly cap, and an individual protection as well. So 3 levels of protection here that I can make the argument that gives them more protection than where they are at today with a fully insured side. The next point is the contract. Here's another big myth, is that what happens at the end? What about that tail? What about termination? What about first-year numbers? What about, a lot of times self-funded, they show me a 12-12. They show us this. They show us that. The contract is a 12-18. And what it means by 12-18 is that the first number is the incurred. So I'm going to use the example of January. January 1 through December 31st, any of those claims incurred in that plan year, if the client terminated, we're going to pay claims for additional 6 months. Again, it's not only 3 months, but it's 6 months. That run-out fee or terminal liability is automatically included in the premium they're paying throughout the year. So there's not any additional terminal liability fees. Again, another big differentiation versus the competitors that are out there or traditional self-funding. And the contract's a strong contract, and it gives them truly a mature contract as well as runoff is included. Again, a big myth that's out there that sometimes we get a bad rap on it. So again, or just self-funding in general. So the protections are there from a contract. The whole idea here is minimize the risk and maximize the savings. From a funding side, I'm going to use that example of $100,000 in premium that the clients, that's what their bill is a year. $25,000 of that $100,000 is going to go towards claims. That doesn't mean that's all there is to pay claims. That's where their chance of a refund is at. 50% or $50,000 is going towards fixed costs. That's admin, stop loss, commissions, profit, the whole 9 yards is in there. And the third bucket is the stabilization fund. $25,000 goes towards that. And again, what we're doing, what's the stabilization fund mean? The definition is it's what every employer pays into for each key healthy partner group. What that is there to do is to help stabilize the rate, the block, etc. of the group. When we underwrite, we underwrite prospectively. So that example of that heart attack with a couple stents put in as a $120,000 claim, you have stabilization fund of the entire block that's trying to help stabilize the rate. So we underwrite prospectively. We, again, the average renewal has been less than 8.5%. Persistency has been close to 96%. Also brings up the point of how do you guys renew your cases? There's 3 really fundamentals that go into the renewal formula. One is we look at the experience. Experience in a small group, as most people know, is not credible or predictable. You have to be a 300-life case to be 100% predictable. So we look at a portion of that. 2, a big weight is what is the prospective risk index of this group? What's the 12 months risk going to be for this group over the next 12 months? How are we looking at what's going on in the group? And 3rd is we look at the block. Those are the 3 components that heavily weight how the renewal comes about. So again, it's full transparency. You know exactly what's going on. From a plan features with the product, again, deductibles $250 to $10,000. Dual options start as low as 10 lives as long as there's an HSA. If it's a PPO, you want to start at 20 lives to have a dual option. And then when you get to the 50, 75 range, if you need to have a triple option, that is applicable. You design the plan, though. You work with your INA specialist, INA rep to say, here's what we've got, here's what I want to do. Coinsurance range 100 to 50. The only things that are kind of set are office visit specialist copay, 20, 35, or 30, 45. Urgent care is always at $50. Big question comes out about ER. Right now, we made a switch. We went to deductible coinsurance, and on January 1, we're going back to putting a copay back in for ER. So again, those are the things that are kind of set. Here's one of the differentiations, though. The minimum care standards for all 27 chronic conditions are covered at 100% with no copays or deductibles. And Mike and his team have handouts that'll go along and discuss in more detail. And this is for the PPO. And HSA, you can't pay 100% or it would disqualify the HSA plan. But let's talk about this for a second. People talk about wellness plans when I'm around. United came out with this new wellness plan, and here it is. And for that 15-life employer, that 20-life employer, I asked the question, they tell me about they've got a wellness plan. I said, well, tell me about it. Well, we get a pack of what did it do? It paid for physicals, immunizations, everything else. How many employees had a physical last year? How many of your kids had immunizations? How many of your people are getting their minimum levels of care done? I don't know. Well, how's that wellness plan working? It's not to talk down to somebody, but it's to help employers and brokers and consultants realize that it's more than just a physical. It's more than just a health risk assessment. It's more than just doing blood work once a year. It's about throughout the year understanding what's going on. So with our 27 chronic conditions, we have minimum levels of care that are established by the American Medical Association. So the example I would give out there is somebody who has hyperthyroidism. Well, somebody that has hyperthyroidism, and with the deductibles being pushed up as high as they can be, is they're supposed to have labs every quarter. Again, the initial visit, whatever pays 100%, but the ongoing things associated with those chronic conditions, typically in the carrier side, are not paid for. They go towards deductible and coinsurance. And again, I'm relating to PPO only here because HSA, you can't make it 100%. But what we're going to do is that for that lab work, for the things that are associated with those 27 chronic conditions that you'll have a handout on, we're paying 100%, no copay, no deductible, no out-of-pocket. The point is, good health is good business. We want the people to get into the doctor. We want them to get the minimum levels of care done. Put your money up, put your money where your mouth is what we've said to our people, and then if we believe in so much of this, we need to push this out into our product. So this was rolled out July 1st. I'm not seeing any carrier in the marketplace that has that. It is a differentiator. It does help, control healthcare cost. What we see, and you'll see it later on, is that our ROI, return on investment, for our chronic disease management program, in the first year, it's anywhere from 4 to 7% because you don't have that benchmark. But it's years 2 and beyond that we're seeing 11 to 17%. Again, what's that translate into? That translates into better renewals. It translates into better claims experience. It translates into healthier employers. It translates into employers understanding what is going on with their health plan and actually having meaningful data behind it. That's what we're talking about here. From the RX side, 10, 25, 50, 15, 35, 50, 20, 40, 80. Couple different RX vendors we work with. Caremark is one. Catamaran is another. Two of the focused that are there. Catamaran was Informed RX and Catalyst merged together in July and became the third largest PBM prescription benefit manager in the country. Both of them have the same exact contract with us. They have the exact same amount of pharmacies, approximately 67,000 throughout the country. The difference between the two, one over the other, is I will tell you Caremark has put about 32 drugs that they truly no longer cover, that they're not even on a third tier. We've seen 12 more that are coming January 1, typically hinge around diabetic supplies. And so, again, we put a choice there. I would tell you probably 85 to 90% of our new business is going on Catamaran because all that stuff is covered. So, again, just from an RX side. Routine annual vision exam covered up to $150. Again, there is no network affiliated with that. They go to where they want. The two most common ones, Walmart and Target want their money up front, so they just have to file a claim form and get a reimbursement back. COBRA HIPAA administration is included with the product. That's the full-blown where we're sending out the coupons, collecting the, doing all the, you want to call it dirty work, so the employer does not have to be, caught in a bad situation. And then the compliance services with healthcare reform, all the different notices that have to be put out. Wally Gray, one of the top ERISA attorneys in the country, has been 12 years on our staff, full-time with us, and that's all his job is to do, is keep our brokers, consultants, and clients compliant and be there as a service when we talk about creative plan designs. A couple of last things before I end here is that behind all these things we talk about with risk management is AHDI. AHDI, American Health Data Institute, is our risk management company. It's been around for about 12 and a half years. The executive vice president of that is Nancy Blau. Nancy's background is she was the deputy department in charge there of insurance in Indiana, and from there she went on to Ford Motor Company in the heyday in the early 90s, where they were 100,000 plus, a couple 100,000, all these different Blue Cross plans. Data for data's sake is what she said. She could not make heads and tails of the data. So coming from the employer side, coming from a risk management side, and coming from a TPA side is what we've brought together here with this data. And we look at it from both the supply and demand side, meaning from the user side as well as from the doctors and hospitals. You're starting to hear more about transparency, what's the cost of different things, how do we understand different things, all those different pieces out there. That's what you're being brought to the table here. We look at it from the claim side, eligibility, and pharmacy side, and then again, what the data is performing is being able to, sorry about that, wellness initiatives, preventive care, illness management, and risk management as well. So all those different things is what is being brought to the table here. It is something different. It is something that we think makes us stand out different than the others, but it's the same thing we do on our 30,000 national life cases that you have to bring to the table. A couple of things here. Stratifying, looking at data, what does the data do? It identifies the risk, and again, putting different things around it, stratify the risk, understand the risk, look at the cost drivers of the plan, implement integrated wellness programs, work with the employer to, employee to educate this risk taker, and then be able to benchmark, measure, and demonstrate outcomes for accountability. That's the difference maker here. Kind of steps to controlling it, again, step 1 to step 5. Things that I just showed on the circle there is that it's really turning the data into intelligence. That's kind of our tagline is don't just have data for data's sake. We've talked about the so what rule, but really turn data into intelligence. Make it actionable, make it talk, make it do something different. That's what we're trying to do here. From a wellness side of things and stratification is everybody's got the bullseye that they focus on where, again, 20% of the employees are driving 80% of the cost, so that red bullseye here. But it's the yellow and green area that you can't we don't want those yellow and green area to get to the red. So managing inside out and outside in is how we look at stratifying risk. We stratify risk into 4 different stratums. Stratum 1 is somebody that's healthy, doing everything they're supposed to be doing, just getting communication out. Stratum 4 is somebody who is, 3, 4, 5 chronic conditions, a bunch of comorbidities, and be able to educate and put a plan together, having the nurses communicate, and being able to get back to you and the employer, what are you doing with our high-risk people? What plan of action have you had? What contact have you had with the people? It's being able to give you that information. Again, in a ASO or ERISA side of things, it's always been, it's HIPAA, how we can't know anything because of HIPAA. Well, in an ERISA plan, the employer owns the data. In a fully insured plan, the carrier owns the data. Again, you've got to put different measures in place with a HIPAA officer, but again, it's information and you as a broker consultant can know. It's full transparency to you. One of the things we do have done here is that we do include the health risk assessment. We do include putting strategy around wellness plans. It's part of what we do. But this health risk assessment, a lot of people have health risk assessments, HRAs, and I just want to point out a couple of differences with ours. One, it was done in conjunction with the Duke University Medical Center. 2 years ago, with health risk assessments, there was a notion that came out. It had to be GINA compliant. GINA compliant means that you can no longer ask family history on the health risk assessments. and that's where a lot of people would try to be able to gauge into getting at different chronic conditions. One of the things that's different with us is that our 27 chronic conditions are embedded into the question. So it allows us to get at folks, identify them earlier. Again, that's if people are being honest. And typically it's the first year, it's 50 to 60% that employees are actually honest. Whereas the second year you see it, I know it wasn't shared, I know it wasn't here. Once they complete that health risk assessment, not only do they get a report out, but the employer gets a report, allowing them to know everything going on with their plan. What we've done with these health risk assessments is when we design plans and talk about compliances, some employers today that have done nothing in the wellness side just want to take a baby step, and my recommendation to them is, how about just starting with a health risk assessment? Come January 1, they have 30 days to complete a health risk assessment online, and if they don't, here's their rate. By law, you can charge up to 20% differential, not being discriminatory there. So again, you can design plans, you can design incentives, and that's the most effective incentive we've seen is when it comes into contribution strategy. If you do this for everybody, if you're doing it, that's great. Here, we're just going to continue paying at this. If you don't, here's your rate. So again, it's building a foundation. If you try to do too much in wellness, year one, it will go over the employee's head. When you put a strategy around having a 3-year strategy, it allows the employees to buy in. It shows the employees that the employer has thought about this, and not just because it's the biggest, fastest buzzword out there is wellness. They've thought about it. That's what the difference is here. Again, just showing you, here's what the screenshots are. Again, what summary they get back, a lesson plan, that's associated with it. It's a little bit different. At the end of the day, we want to demystify the data, turn it into intelligence to help manage the health of the members and control unnecessary cost. Here's a sample report that you would get, is that we would list all 27 chronic conditions that you would see based upon your membership, a minimum care rate, who's actually doing something and who's not doing something, and be able to tie back into incentives based upon that. Here's the minimum annual care recommended that we went to with all the 27 chronic conditions, that the things that are paid at 100%. It's things like this that differentiate you as a producer. It's things like this that your client's looking for, suggestions and solutions for the future. This product will compete against the exchanges. It will. It's going to go fast, and it's growing at a very rapid pace. The last two things I want to show you is this is kind of what you get from a 6-month and annual basis. It's a health plan balance sheet, because a lot of times people don't want to flip the reports. So we're going to, part of our service team, along with Mike's team, is that you have an account manager that's going through these reports and putting something together that would say, here's what the reports tell you. The challenges and opportunities on the left side, as well as the possible strategies. No different than you think about when you go get, we take our car in to get more checkups than we do on ourselves. So it's getting to the, when you get that report back, when you go get your oil change and here's what's going on, this is kind of what we're looking at. We're taking those reports into a one-page summary and then looking back into those reports to talk about the actionable items as what can be done. We talked about ROI. This is what, 4 to 7 to 1. Like I said, years 2 and beyond, it's 11 to 17%. The big things here is a healthier workforce, impacting absenteeism, workers' comp, disability, productivity, employee retention, attitude, and performance. It's really the only mid to long-term strategy to control healthcare costs and empower employees to become better consumers. Again, consumerism is coming out there. It's all over the marketplace. Now you have tools in your, and products in your toolkit to bring something different to the marketplace, because, again, some people will say, I want nothing to do with it. That's fine, too. It's not for you. But I will tell you, these products are not going away, and if anything, they're going to be, we're looking to build upon this, go into bigger markets, go upstream into higher case sizes, because it's what employers are asking for. If you can protect the employer, show them something different, and it's not, take the horror stories out of the way, that's what they're looking for. And at the end here, just as in summary, is that you as a broker consultant, what are the solutions you're looking to provide in the future with something like this? It's one, it's becoming a healthcare risk manager. Again, anybody can just show different spreadsheets and different carriers, but if you're not really truly trying to manage the risk of the employer, it's trying to differentiate you, because there are more people that are going that way. managed by actionable data, looking at the data and doing something with it versus just saying I've got data to have data. Measure and benchmark results. Show return on investments. Show, if we do these blood draws, what do we do this year? What do we do next year? How can we help track that with you? It's things that we work with you to do. Target resources where they have optimal benefits. Maybe all of a sudden we see how the HRAs that it's, we have a lot of cancer history. We have this or that. Maybe we need to have mammograms done. We need to bring a mobile coach in. But taking data and doing something with it versus just because there's a buzzword out there about wellness. Again, change the paradigm here. Realign the design of the health plan to match the health needs of the members. For the first time, you're going to see details in that small group as to what's being used, what's not being used. It's almost like when you go buy a car. If I could buy a car with all these options that I thought I wanted, then I could make some changes going forward. I wish I could have done that. That's what you have here. And then finally, engage the members and consumers of health. Having the tools to make a difference in putting a strategy, and especially a 3-year strategy, it shows you're bringing something different to the table versus just a one-hit wonder. Here's what we do for this year. We'll switch next year. Again, 2014, I know it's going to be different. I know there's going to be changes, but I will tell you this product is around. This product will be there. It is a solution in the marketplace today. Mike, that's all I've got.
That's all you got today? My goodness. That was a lot. And Heath, I want to thank you. If you have questions, continue to put your questions up. We have a few questions, Heath, if you don't mind fielding a couple for us. Certainly one of them, I'll answer this one, being asked if the presentation is going to be available at the INA site. And yeah, it will. Most likely we'll have that back up there today. By end of day, but definitely by tomorrow, so you can go to our site and look at this at your convenience. Another question asked is the KHP product. They're questioning it said it's a 10 to 125, correct?
Correct. 10 to 125 covered people, employees.
Right. And then if you had larger groups, we would just move that off the KHP product and move it more towards the actual next step up. Partially self-funded plans, correct? And you can go to how big of a group?
30,000. I mean, our largest case is 32,000.
Okay, so you can handle the big ones and you can handle the little ones. And we know INA, we can validate and say you can handle the little ones because we write a lot of little business with you. Our average group size, though, I think is pushing about 22 lives. To be honest with you, even though we do go as low as 10. Another question that was asked, state availability, are there states that you don't market in? I mean, we always have people that get on here that are from the tough states like New York, New Jersey. They're always begging for something. Where are you at with this product?
California and New York are still no's. New Jersey is getting close.
Okay.
I think
every place else pretty good?
Yeah, there's only 4 or 5 states. I don't have the actual map.
Okay.
One of the team members should have that, Mike, but if you're not, just let me know. But there's only 4 or 5 that's not applicable. And again, that's where we look at it, where is it situs, the state, the situs state.
Okay.
They could have employees in different states. That's not a problem. One of the things I didn't hit on, I guess, is that we work with 109 different networks. We've got the national networks such as Cigna, such as Coventry, such as Humana, in different marketplaces, but we're trying to make the best fit for you.
Okay. One person asking, do you do the new mandated wellness benefits? And the answer to that is yes. So those are the few questions that we had. If there's a few more here that pop up, we'll cover those. But for sake of time, we'll move forward.
Mike,
yes.
Let me ask one other thing that's a big thing, a big push being asked. We're getting is SBCs. It's included in what we do. So the benefits summaries, et cetera, that have to be put out there by law now. That's included with what we do.
Yeah, and just that's great you brought that up, and I'd also like to add in there my 2 cents worth too, that people who say that groups are worried about self-funding and what's going to happen at renewal and all these types of things, any group that you're looking at for a 1/1 effective date, my personal opinion is if the training doesn't change, and I doubt that we can correct it even if the election goes away that maybe I would like it to go, we'll just say that, come 1/1/2014, No medical questions, guaranteed issue, and we know for a fact that those rates are going up at least a minimum of 30% every place I've ever heard. I've seen nothing less. If a group, and you as an agent, those groups could decide to be mad at you and be upset because, oh, you didn't warn me even though it's been told. Those groups could run to the exchange, and that's commission you lose. Where this product here, this is the time to start putting these in place and getting these people converted over. They're going to be happy with you come 2014, and it's a way for you to stabilize your commissions and give yourself a guarantee because no one knows otherwise. Here's one question here. Will deductibles be limited on these plans after the ACA limits of $2,000, $4,000 go into effect?
Say that again, Mike.
Will the deductibles be limited on these plans after the ACA limits of $2,000 and $4,000 go into effect?
On the it's not been determined yet on the self-funded side. There's different interpretations of that, so I don't have that answer yet.
Okay. Thank you. And then just move forward on this thing here also. The alternate funding, we offered you some pieces to help market this product. We'll give you a little marketing toolkit. So if you call in today with questions or you want to get this toolkit, call in, get with one of your reps. We'll give you these two pieces that can be used as mailers. If you need them in an HTML format, so you can email them out, let us know, and we will get these out to you today as our thank you to you for coming aboard and also help you get started in moving groups in this direction. Also, we have our Costa Rica trip for top producers this year. We've been doing cruises for the last 15 years. This year we decided to do a land-based because that was the request from a lot of people that go all the time. I'm very excited about this one. It's an all-inclusive Western resort in Costa Rica, and it looks beautiful. Our boss went and viewed the place, came back and gave us pictures and a story about it, and I just can't wait to go, and we'd love to see you there. And between now and January 1 effective dates, we are doing double points for medical groups that you write. And typically you need to write 75 lives in order to make that happen. But with double points, now you can go for as little as 38 points, and you could come join me in Costa Rica, and we'd love to have you. So that literally could be one or two groups, and you're in with this particular promotion. And if you have questions on this, contact your rep. He'll give you all the details. And everything you write with INA counts. If you are somebody who writes annuities and life, if you write dental, if you write short-term disability, everything goes towards getting you to Costa Rica. So with that said, I want to thank all of you for being here and attending. I will leave this up here for the next 5 minutes for those who need the phone number. Thank you, Heath, and make it a great day.
Thank you.